Is it anemia of chronic disease? Iron deficiency. Iron to deficient. Where is the bleeding? Low, yes. Maybe you are right. You are thinking in what? Yes, yes. So this patient with chronic use of NSAID, this patient with chronic use of NSAID has now fatigue and microcytic anemia. The most likely is chronic blood loss due to NSAID associated gastropathy resulting in iron deficiency anemia. Expected lab study associated with iron deficiency anemia include low serum ferritin and low iron, which reflects the total body iron stores. Increased serum transferrin, which has an inverse relationship with iron. Transferrin, the primary iron transport in the plasma, is often reported as TIBC. Low transferrin saturation, which is the ratio of serum iron to TIBC. Yes. Anemia of chronic disease. Anemia of inflammation is characterized by sequestration of iron in response to hepcidin and certainly inflammatory cytokine. Serum iron is low, but ferritin in acute phase, sorry, serum iron is low, but ferritin in acute phase reactant that may be increased due to underlying inflammatory condition. Transferrin is reduced in response to inflammation. So TIBC is low. Transferrin is usually transferrin saturation typically normal and or mildly low due to reduced circulating iron. The low level of inflammation in osteoarthritis does not usually cause anemia of chronic disease. Sorry, 19 before 1950. If the houses is before 1950, then it is lead, or before. uh, I remember 1950, maybe not 1950. Okay, but it is not looks like lead poisoning. She is menstruating lady, menstruating woman, and uh, uses lots of pads. So maybe looks like it's maybe due to menstruation. Sorry. Yes. Okay. Lead poisoning. Look at the lead poisoning. House built before 1978, and like eating dirt or paint chips. This is another thing you like the babies or who has the tendency of pica. Sorry, who are pica, like they eat whatever comes in front of them, like they got this type of problem, like lead poisoning. 1970. Yeah, okay. But iron deficiency. Okay, iron deficiency anemia, thalassemia are the most common cause of microcytic anemia. Both patients with fatigue and pallor and history of prolonged breathing heaviness or poor dietary iron intake raises suspicion for iron deficiency anemia. Distinguishing lab findings, IDA included decreased erythrocyte count, inadequate synthesis, and elevated red cell distribution width due to variable iron available throughout the day. In addition, IDA may be associated with reactive thrombocytosis, platelet more than 4 lakh in response to low RBC count. This change is due to megakaryocyte and erythrocyte sharing a common progenitor cell. Although thalassemia should be on the differential diagnosis of a patient of Greek ethnicity with family history concerning for inherited thalassemia, this patient has a signs of IDA heavy means decreased erythrocyte thrombocytosis. Therefore, iron studies are the best next step. Correction of IDA is necessary prior to evolution of thalassemia with hemoglobin electrophoresis because concomitant iron deficiency can lower HB hemoglobin A2 and mask the diagnosis. Okay. Is it too sorry? Yes, I think that excision because it is fixed, firm, or you are choosing what? Maybe you are right. Yes, yes. Think that I think that you should do imaging first. This older man has enlarging. So this older man has an enlarging left breast mass that is firm, fixed, causing nipple inversion, infiltration into the lactiferous duct behind the nipple. This presentation is suspicious for breast cancer and should prompt imaging, mammography followed by tissue sampling, core biopsy. A workup that directly mirrors that palpable breast mass in a woman. Breast cancer is less common in men than in women, but shares many of the same risk factors, including increasing age, excessive estrogen stimulation, increased adipose tissue aromatization, or androgen to estrogen in obesity. As in this patient, most affected men have unilateral firm, non-tender subareolar mass, often with nipple involvement. The mass initially go undetected, or it may be noted incidentally after unrelated trauma. So, as likely happened in this patient who noticed the lump after being struck in the chest, although fat necrosis can although fat necrosis can occasionally have a similar clinical presentation, malignancy must always be ruled out first. Imaging or biopsy mammography is the first line imaging with adaptation. Smaller tissue compression paddles are necessary. Breast ultrasound may also be helpful to further characterize mammographic abnormalities and aid biopsy. If suspicious features, microcalcification, speculated margins are on imaging, a core biopsy is performed. Yes, direct excision without preceding imaging or biopsy may be considered for a mass that is clearly benign on physical examination. Well circumscribed, non-fixed, soft lipoma. In contrast, this patient's mass has concerning feature like firm, fixed nipple changes that warrants diagnosis before excision. If breast cancer is present, a more extensive surgery. A breast cancer, if breast cancer is present, more extensive surgery, mastectomy will be necessary to reduce the risk of recurrence. Okay, for as the mass is abnormal feature, as the mass has abnormal feature like firm, fixed nipple changes, so that's why we confirm first, then we do the excision, or if mastectomy needed, we do the mastectomy. If it is like soft, like lipoma or simple mass, then we can do excision biopsy. Then core biopsy, yes. Yes, I think that transfusion. This patient has multiple. This patient has multiple sites of blood loss, hemothorax, decreased breath sound, 1.5 liter blood from chest tube, hemoperitoneum, tender abdomen, positive focused with sonography for trauma, fast examination and femur fracture, left thigh deformity. In the setting of blood loss, a systolic blood pressure less than 90 millimeter of mercury along with tachycardia more than 120 per minute. Sorry. Okay. Altered mental status, eye closed, moaning, and decreased capillary refill. Cold, clammy extremities suggest at least 30% loss of blood volume. Suggest at least 30% loss of blood volume. Generally classified as class 3 hemorrhage. This presentation is consistent with hemorrhagic shock from bleeding at non-compressible site, chest or abdomen. Two types of blood is optimal choice for transfusion. However, depending on several factors, trauma versus non-trauma center presence of antibody, it can take significant more than 20 minutes to prepare after type and cross matching. Patient in hemorrhagic shock such as this one can exsanguinate in that time. Therefore, in such situation, group O Rh negative should be administered unless type specific blood is immediately available. Most hospitals keep O Rh negative blood universal donor ready for use in emergencies to prevent hemolytic disease of the newborn in future pregnancy. It is particularly important that this type of blood given to women of childbearing age, as in this patient, uh, and to young girls. In men and women past childbearing age, ORH positive blood can be given. Okay, this is important. So ORH positive blood can be given after childbearing age or any man, but this young woman childbearing age, we give ORH negative blood to prevent hemolytic disease of the newborn. Okay, and that main thing is blood for blood. Like we limit use of crystalloid, limit 1 liter of fluid. We have found one question that if we give more and more crystalloid, it will increase coagulopathy. Like so, clot formation. This there is a disturbance of the clot formation, and okay, that's why we limit use of crystalloid. You want me to read the box? Okay. Management of hemorrhage due to trauma, control bleeding, control bleeding from any compressible site, early transfer to location, trauma center, operating room, angiography suite for definitive care and control of hemorrhage. Give a blood products early, transfuse blood product early in the resuscitation, massive transfusion protocol ratio 1:1:1 FFP versus packed red blood cell or platelet to minimize the risk of coagulopathy. Limit use of crystalloid, limit to 1 liter if a patient is hypotensive, and switch to blood product as soon as possible. Okay, Is it lymphoma, Hodgkin? Okay. Is it head neck cancer? Head neck cancer is squamous cell. Okay. It. Okay. Malignancy is extremely likely in a patient with persistent more than 2 weeks. Persistent more than 2 weeks, palpable 1.5 centimeter firm neck mass, a smoking history, and no preceding infection. By far the most common malignancy in the upper cervical node is mucosal head and neck squamous cell carcinoma. Indeed, the first and the only apparent manifestation may be palpable cervical lymph node representing regional nodal metastasis. Referred autalgia is another common presentation symptom facilitated by either glossopharyngeal nerve innervates both the base of the tongue and the external auditory canal EAC, or the vagus nerve, cranial nerve 10, innervates part of the larynx, hypopharynx, and the external auditory canal. Identification of the primary source of head neck squamous cell cancer is essential to direct treatment through examination includes endoscopic visualization using laryngopharyngoscopy as well as neck imaging, CT with contrast to evaluate the primary site and characterize the cervical nodal disease. Fine needle aspiration of the lymph node is advised over open biopsy to avoid tumor seeding. Next. Polycythemia, if hematocrit count is more than 65, maybe polycythemia. There are some feature of hyperviscosity and other like look at the other parameters. Platelet is high, leukocyte is actually high, so all the things is raised. Maybe polycythemia. I think that as she has blindness, we should remove some blood from the body. Yes. In iron, uh, there is no other way of removing the. You want. Okay. Polycythemia vera. Okay. Polycythemia vera. Okay. I was thinking like in case of neonatal polycythemia, uh, hematocrit count should be more than 65%, not for like adult patient, maybe. Because we have found another question where there is neonatal polycythemia. Okay. Polycythemia is a clonal myeloproliferative disorder characterized by erythrocytosis. Most cases are associated with JAK2 mutation. Patients are often asymptomatic at diagnosis but may present with symptoms related to increased blood viscosity, transient visual disturbance, hypertension, thrombosis, increased red blood cell turnover, gouty arthritis, itching after warm showers, aquagenic pruritus is common. Physical examination often show facial plethora, rudisianosis, rudisianosis and splenomegaly. Unlike other causes of erythrocytosis, chronic hypoxia, erythropoietin producing tumor patients with polycythemia vera usually have normal oxygen saturation with low erythropoietin level. Complete blood count often shows an increase in all three cell lines. Serial phlebotomy is the mainstay of treatment in polycythemia vera. It creates a relative iron deficiency and reduces hematocrit level to normal range. Bone marrow suppressive drugs, hydroxyurea may be added in patients are at risk of thrombosis, previous thrombosis, and advanced age. The terms polycythemia and the erythrocytosis are often used interchangeably. However, not all polycythemia is truly erythrocytosis. Polycythemia implies a lab finding of elevated hematocrit and may be diagnosed as relative, usually due to reduction in plasma volume, or absolute due to increased RBC production. Only absolute polycythemia involves erythrocytosis, increased RBC mass. Absolute polycythemia erythrocytosis is seen in patients with polycythemia vera and secondary polycythemia, chronic hypoxia, secreting tumors. Yes. Splenectomy is useful in many antibody-mediated hematologic disorder. Splenectomy is useful in many antibody-mediated hematologic disorder, autoimmune hemolytic anemia, idiopathic thrombocytopenia. In polycythemia vera, the primary problem is myeloproliferation within the bone marrow. Splenectomy would not reduce the hematocrit. Is
normal and he has
Apart from iron and thalassemia, microcytic hypochromic anemia, there are four differential.
okay, so
Yes, BC is low, so it is not actually fits the iron deficiency anemia. No, it does not fit the anemia of chronic disease. In anemia of chronic disease, anemia is locked up within the macrophage. That means ferritin is high and the other parameters are low. In here, iron is high. Look. This patient is on anti-TB drugs, and in the anti-TB drugs, one of the drug is absent. Uh, like you give the right along with one drug. It is sideroblastic anemia. And another thing, like I have told you, like microcytic hypochromic anemia has 4 DD. It's iron deficiency anemia, thalassemia, sideroblastic anemia, and anemia of chronic disease can comes with iron deficiency anemia. Uh, like it's I said that you can write in various way like SITA sita. Sita is somebody's name. I remember it's ITSA. For for differentials. No. Iron deficiency anemia, thalassemia, sideroblastic anemia, and anemia of chronic disease. Yes, you can remember Sita, sideroblastic, I for IDA, T for thalassemia, and A for ACD, anemia of chronic disease. Anemia of chronic disease is usually normocytic normochromic, but in the long run, it can come with microcytic hypochromic anemia. Okay, so the most likely diagnosis in this patient is acquired sideroblastic anemia. Sideroblastic anemia consists of different types of anemia characterized by defects in heme synthesis, mitochondria, and ring sideroblast, a nuclear erythroblast with mitochondrial iron granules surrounding the nucleus. They can be congenital, presenting in children or adolescent, or acquired, most common. Although acquired sideroblastic anemia may be related to clonal abnormalities, myelodysplastic syndrome, clonal myelodysplastic syndrome, they are frequently due to reversible etiologies, alcohol, malnutrition, medication that lead to pyridoxine-dependent impairment in the early steps of protoporphyrin synthesis within the mitochondria. This patient is on isoniazid, a well-known pyridoxine antagonist that can be acquired sideroblastic anemia. It frequently manifests as microcytic hypochromic anemia. It frequently manifests microcytic hypochromic anemia, simulating iron deficiency anemia, as as can sometimes be seen in as can sometimes be seen with iron deficiency anemia. Usually, two groups of RBC can be demonstrated on microscopy: hypochromic and normochromic dimorphic RBC population, likely reflecting the defective heme synthesis. Unlike iron deficiency anemia, iron studies typically revealed increased serum iron concentration, and normal or decreased total iron binding capacity due to mitochondrial mishandling of iron, explaining the mitochondrial iron granules in the ring sideroblast. In contrast, iron deficiency anemia is characterized by decreased serum iron concentration, and high TIBC. In this patient, in this patient with easily identifiable cause of vitamin B6 deficiency, in this patient with easily identifiable cause of vitamin B6 deficiency (INH), administration of pyridoxine is the most reasonable next step. Bone marrow sampling can confirm the diagnosis by demonstrating ring sideroblast. A spec- okay. Bone marrow sampling can confirm the diagnosis in demonstrating ring sideroblast, a specific finding in sideroblastic anemia, but it is not necessary in this patient. Okay. Wait. Okay. Before jumping into the answer, wait. After starting the piperacillin tazobactam, it is this problem started, isn't it? Okay. So the main criminal is the drug. So it is not. Oh, wait. I am explaining. It is. It is not. Yes, heptane is one form of like hep what what is heptin? These actually binds with the RBC and thus causing these heptins, like these drugs. We can call the drug as an heptin because drug has binding site and heptin has specific binding site. That's why drug sometimes called as heptin. That's why this is called heptin cause mediated hemolysis. If you okay, I'm reading the explanation. Just look at the pathogenesis first line. Drug coats erythrocytes. So drug, that means the heptins, the part of the drug, drug coats erythrocytes, IgG binding. There is splenic dysfunction, destruction of the RBC, and extravascular hemolysis, and there may be intravascular hemolysis too. When drug triggers the immune complex, complement mediated destruction of the RBC, intravascular hemolysis. Okay. Okay, these patients hospitalized, these hospitalized patients, acute anemia, dark colored urine, normal coagulation studies raise strong suspicion for drug induced hemolytic anemia. The most common triggers for NSAIDs, diclofenac, cephalosporin, and penicillin, piperacillin, tazobactam. Although drugs can cause hemolysis through a variety of mechanisms, oxidative injury, complement mediated lysis, penicillin, cephalosporin triggers hemolysis when the drug binds directly to the surface of the erythrocyte, creates a heptin for IgG attachment. IgG coated erythrocytes are then identified by the Fc receptor on the splenic macrophage, leading to partial or whole erythrocyte phagocytosis, extravascular hemolysis. Intravascular hemolysis may also occur due to activation of the complement cascade. Manifestation typically arise within hours of drug exposure, include signs of anemia, dyspnea, pallor, weakness, hemolysis, jaundice, and dark color urine, hemoglobinuria. Back pain can sometimes occur in severe cases, possibly due to increased erythrocytosis, the vertebral bone marrow. Lab evaluation will reveal increased indirect bilirubin reticulocytosis with intravascular hemolysis, elevated LDH, and lowered heptoglobulin. Peripheral blood smear typically show immature red blood cell normoblast spherocytes due to partial removal of erythrocyte membrane by splenic macrophage. The diagnosis is confirmed by direct antiglobulin Coombs testing, which detects anti-IgG, anti-IgG bound splenic macrophage. The diagnosis is confirmed by a direct antiglobulin or Coombs testing, which detects anti-IgG bound to the erythrocyte surface. Discontinuing of offending drug is generally curative. Okay. Hemoglobin is low, MCB is high. Is it macrocytic anemia?
Yeah.
Vitamin B.
What is that? Aplastic crisis.
Aplastic crisis, reticulocyte count will be low, absent. In here, reticulocyte count is normal, not aplastic. In splenic sequestration crisis, oh, high. So it is not. Is it due to drug? Is it due to folate? Apart from the high MCV, I don't know how people diagnose this. Okay, medicine is all about guess. Okay, okay. So this patient has progressive exertional dyspnea, fatigue, pallor, generalized weakness due to severe anemia. The most likely cause of macrocytic anemia, MCB more than 100 in this patient with sickle cell disease is folate deficiency. Sickle cell disease is a chronic hemolytic anemia in which red blood cells are typically normocytic and normochromic with a compensatory elevated reticulocyte count. Without an adequate folic acid supplementation or intake, chronic hemolysis can lead to folate deficiency as the bone marrow uses folate in an attempt to produce RBC. Folate deficiency results in lab findings of macrocytic anemia and hypersegmented neutrophil. Due to ineffective erythropoiesis, the expected reticulocytosis is absent and inappropriately low reticulocyte count is seen. Low corrected reticulocyte count, although this patient's reticulocyte count appears normal 0.5 to 1.5%, it is lower than expected sickle cell disease. So expected for sickle cell disease. Adequate folic acid intake via diet. Adequate folic acid intake via diet or supplementation is recommended to correct the underlying folate deficiency. Yes. Anemia, thrombocytopenia, leukopenia. Anemia, thrombocytopenia, leukopenia. Wait, 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 don't jump. Why I am like that? Okay. No, it's not aplastic anemia. Yes, it's ALL. Okay, why it is not aplastic anemia? Okay. Okay, bone marrow failure due to aplastic anemia is characterized by pancytopenia. However, in contrast to a hypercellular bone marrow in ALL, hypocellular marrow of the aplastic anemia does not typically cause bone pain. In addition, hepatomegaly is uncommon with aplastic. Okay, this is new information. So, hypocellular bone marrow of aplastic anemia does not typically cause bone pain. Okay, as there is bone pain, leg pain, along with these aplastic features, so that's why it is ALL. Okay, okay, I am reading the explanation. Okay, sorry. These patients' bone pain and pancytopenia are concerning for ALL. The most common malignancy in children, pathogenesis of ALL, rampant growth of leukemic cell in the bone marrow, which can result in bone pain, classically affecting the long bones, femur, tibia. The dull pain is often more noticeable at night. Children may limp or refuse to talk during the day. Although families may relate the onset of the pain to an episode of trauma, fall, the presence of systemic finding, fever, hepatomegaly, bilateral tibial pain, hematologic abnormalities as seen in this patient suggest a more systemic process. As leukemic cell counts in the bone marrow increase, production of all cell line declines, pancytopenia resulting in pallor due to anemia, and bruising, petechiae due to thrombocytopenia. The leukocyte count is initially low due to concurrent decrease in normal white blood cell production. However, with as the disease progresses, lymphoblasts overcrowd the marrow. Lab evaluation often shows leukocytosis due to lymphoblast spilling in the periphery. In addition, hepatosplenomegaly can occur with extramedullary leukemic spread. Okay, okay, can we stop today? Okay, okay, bye bye. Yes.